Hi, sir. Good afternoon. You are muted.
Good afternoon, sir.
How are you, sir? We give us one more minute because Abhay Allen says descrubbing and joining. Otherwise,
Sure,
we
sure,
will start without him and go on.
sure.
So we are giving everybody time to join till 4:05. ठीक
Great.
है जी? Thank you so
Okay.
much, sir.
Good afternoon, Professor Mani, sir.
Hello, Dr. Siddhartha. How are you?
Good, sir. Thank you, sir.
I'm just sorting out my earphone.
Yes,
It's
sir.
been some time that I've been off Zoom meetings. We've become physical, so
Yes, sir.
restart हो रहा है. चल गया? जो एडिट किया था वो आ गया वहाँ पे? चला. टाइटल वाइटल आ रहे हैं कुछ? आएंगे. चलने दे. वो थोड़े थोड़े टाइम के लिए है टाइटल बीच में.
Thank you, everybody. Thank you, Professor Lalit Mani, for joining us. Dr. Abhay Allens, from his OT, has been joined by this young consultant, and he is also going to be asking questions. To the audience who is here, उसको on कर दो camera. To the audience, camera on कर दो यार. To the audience who is here, this is the second PhD being done by the orthopedics department. First one was Dr. Ramesh Sen, and I was actually the first one, but I discontinued because I went away to Sri Lanka in 2003, so it was discontinued. And the protocol is that this is a thesis defense. There are many people who have joined us online, and there are some of you who are sitting here physically. And we've got people from all over the world. And there will be two external examiners and one internal examiner for this. And there are some of the thesis guides who are sitting here physically present with us. and one or two of the thesis guides will be joining us because they're traveling. So before I introduce the two examiners, I would like to say something. Dr. Siddhartha Sharma has been working on this, and we started work on this about before COVID, I think, if I'm not wrong. And one of the international guides for this is Dr. Stefan Remelt of Germany. And this was a unique idea, and he will be presenting to you. And this is, you are all welcome to ask questions online or even from here. And I'd like to introduce the two external examiners. Professor Lalit Maini is the chief of the orthopedics at Maulana Azad. Am I not right, Lalit?
Yeah, no,
And
not the
he's-
chief yet.
Okay, but his claim to fame is that he has, as editor of the Indian Journal of Orthopedics, he has taken the journal to great heights. Dr. Anil Jain brought it to a certain level, and then Dr. Lalit Maini was elected as the editor when I was and I am proud of the fact that I was the president of the IUA. We think we made a very good choice, and he's taken up the IGO to such great heights that it is now, we get publications from all over the world. Indians don't get a chance. Then we have Dr. Abhay Ellens, who is known to most of us here because of his links through, pelvic surgeries and arthroplasty. He is the chief of orthopedics at AIIMS Jodhpur, and he is joining us online. So the forum would be, we will probably break it up into 2 or 3 sections if Dr. Maini and Dr. Ellens permit, rather than having one long talk. Since we have 3 or 4 objectives in the thesis, I was wondering that if we finish objective 1, we can look at a couple of questions from anybody, from the examiners and from the audience. And then after every objective, I have a few questions. At the end of it, we have the full-fledged viva voce. If that is acceptable to everybody, Dr. Maini, with your permission?
Yeah, I think it's fine.
Okay, thank you, sir. I hand over to Dr. Siddharth now.
Thank you, sir. Very good afternoon to all of you. Professor Maini, sir, are my slides visible, sir?
Yeah, they are.
Thank you, sir. So, I will be defending today my PhD thesis, which is titled Malunions of the Talus, Pathoanatomy, Radiological Features, Alterations in Foot Biomechanics and Functional Outcomes. And it's been a privilege to have been guided by Professor Mandeep Dhillon, who is one of the stalwarts of foot and ankle surgery internationally. At the outset, my thanks to my co-guides, Professor Mahesh, Dr. Sharad, Dr. Nilesh, and of course, Professor Stefan Remelt, who has done a tremendous amount of work on Talus malunions, in addition to him being a stalwart in foot and ankle surgery. My best regards and my thanks to my doctoral committee members, especially the chairman, Professor Rajesh Gupta, and all my DC members, Professor Paramjeet, Professor Mandeep, Professor Saravdeep and Sameer Agarwal, sir, Dr. Tulika and Dr. Kamal Kishore. It has been an arduous journey, but I have been guided by the best. So why did we choose this topic? Because talus malunion is not something which is frequently talked about. Well, because talus fractures are increasing and talus malunion is a very common complication. So in all of the non-operative displaced fractures, malunion happens in about 100% of the cases. Even in operated cases, it happens in about 20 to 30% of the cases, as shown by the systematic review. Now, people keep talking of avascular necrosis all the time, and what do we do for AVN? But the fact is that the AVN people don't do very badly. However, the work on the literature on malunion is very sparse. So when we did this lit search, we came up only with 11 studies, and malunion is a significant problem because it has poor functional outcomes. Then secondly, there are no standardized radiological parameters. So if we were reducing a fracture neck of femur, we would look at some angles and try to say whether this is anatomic or not. This is an intraoperative image. And if I asked 5 people whether this is anatomical, all 5 would have some different answers. Also, the typical description of a talus malunion is varus, but we know that deformities are 3-dimensional in nature, and this really takes away from the complexity of the deformity. Because of our limited understanding, the corrective strategies are also poorly defined, and most of these studies just talk about restoring the medial column length. They don't really look at the deformity in 3 dimensions. So with these broad questions in mind, the aim of this thesis was to define first the normal, followed by the abnormal talar neck anatomy in a malunion. And we also wanted to quantify the effect of this anatomy on foot biomechanics and functional outcomes. So to achieve these aims, we broke this down into 6 objectives. Ankit, Dr. Abhay, can you please take this? So the first objective was to standardize the techniques to measure the relationship of the talar neck with the talar body so that you can actually quantify reduction and quantify malunion.
Just hold on. I'll just send it a link across. Just hold on. Dr. Mani, just a minute away to joining. Give us
Yes.
a minute. Is the same link you sent me?
Yes, the same link, sir.
Okay, please go on.
Okay, so the first objective was to standardize the measurement techniques to define the anatomy. The second objective was to define the normal values of these angles in the Indian population. Thirdly, we wanted to study what happens when you have a talus neck fracture. There can be subtle alterations in these angles and how these alterations will affect the outcomes. Fourthly, we wanted to look at people with a gross talar neck malunion and what is the effect on foot anatomy. Then we went ahead to quantify the effect on foot biomechanics and functional outcomes. And finally, we developed some 3D printed models, including jigs, to help us guide correction.
I would like you to stop for a minute.
Yes.
We'll let Dr. Abhay join us.
Yes.
You allow him to join and then read out the objectives again.
Okay,
and
sir.
then we go forward. He's
Right.
still joining.
Right.
सेम ही हाइट होगा या ऊपर चले जाएगा या नीचे आएगा देख लंबा भी हो जाता है तो ऐसे ऐसे चले so as he joined Dr. Abhay Dr. there
Not yet, sir.
we'll give him 30 more seconds and then we'll do
So this is the overall work plan for the thesis. For the first arm, we chose CT studies of the foot, and we standardized the measurement techniques and determined the normal values. For the second arm, we chose fractures without gross malunion. By gross malunion, I mean that the foot did not have a visible cavovarus deformity, and we looked at radiology, functional outcomes, and pedobarography. For the third arm, we chose people who did have a gross talus malunion, and then we looked at their radiology, functional outcomes, and in this group, we also did rapid prototyping. So this is my first objective, which was to validate the radiological parameters to describe the talar neck anatomy. So before we went into this, we actually performed a scoping review and meta-analysis to see what is out there. This was followed by a feasibility study to see if the angles and all could actually be measured. And we followed it up with a reliability study where we looked at the inter and the intra-class correlation coefficients. So when we did a PubMed search, we found some 21 studies. Most of them were cadaveric, but some were radiological. We saw that the neck length, width, and the neck height had been described in the literature. We meta-analyzed their values. But we noted that the medial and the lateral talar neck lengths are not defined. Now, orthopedic surgeons refer to the medial talar neck length all the time for talar neck fractures, but no study so far had quantified this. As far as angular measurements in different planes were concerned, there was a lot of variability. We were able to calculate some of the pooled values, but the big takeaway points from this scoping review was the need to standardize measurements on CT scans, be it 2D or 3D, and then also to describe how to actually measure the medial and the lateral talar neck lengths. So for the feasibility study, we standardized the Talus reference planes. This is very important because CTs are obtained in any position, especially in the trauma setting. So you need standard anatomical planes. We standardized the landmarks and the measurement techniques, and we actually saw whether you can correlate the 2D measurements with the 3D measurements. So standardization was done in all three planes. And this is a video where we are showing how to standardize a CT cut. Now, as you can see on the left, we are aligning the axis to pass through the midsection of the talus neck and body in the sagittal plane. On the right, we can see that the axis is being made parallel to the talar dome. And when you have aligned the sagittal and the coronal planes in the center, now you have the standard talus axial plane. And why do you need this? So here you can see that this is a non-standard plane, and if you have a cross section, you will not see the entire talus neck and the body in one go. But if you have a standard talus axial plane, you can see the body, the neck, as well as the head in one plane, and this is the plane where you should be doing all your measurements. So similarly, we also standardized the sagittal planes. For this, you have to work on the coronal and the axial images like this, so make it parallel to the talar dome. And then in the axial plane, we make it parallel to the talar body. So this is how you get a standard sagittal plane. And again, in a non-standard plane, you don't see the full talus, but in a standard sagittal plane, you can see the whole thing. Then we also standardize the coronal plane in a similar way. As you will agree for a talus, for a femoral neck, if you want to measure the torsion, so you have to look at the proximal end and the distal end. So for a talus, similarly, you have to look at the talar body, which is at the back, and the talus head, which is at the front. So here are two standardized sections of the body and the talar head, and then we overlap the two on each other. And you can see in one image, you see the talar body and the talus head, and this allows you to measure the talus neck torsion, which is very important. So we saw that these standard reference planes have never been described, and we were the first ones to do this. So having standardized the planes, we moved down to standardize the measurement techniques. So this is how we standardize the declination angle, which tells you the frontal plane angulation of the talus neck. So these are two reference lines of the talus body. This is the mid axis of the talus body.
May I stop you? How did you make these reference lines? How do you make it repetitive?
Yes, sir.
How did you make
So all of these landmarks have been described well. So if I can go back.
Yeah.
So these 2 points are the lateral and the medial most points of the posterior most part of the talus body on a standard talus axial plane. The medial and the lateral most points.
What is the posterior most part?
So the posterior most point, which would be determined by a line tangential to that thing. So 5 millimeters anterior to this, we have 2 points. So we take the centermost points of these two lines, and this is the mid talus axial body. Then we are choosing the medial and the lateral most points of the talar head, joining them in a line, taking the midpoint and dropping the perpendicular, which is the center of the talus head. 5 millimeters posterior to this, we have defined the talus neck, the midsection, and by joining those 2 points, now you have the mid talar neck axis. So when you look at the angle between the talus body and the talus neck axis, it gives you the declination angle, which tells you how much is the varus deformity. The medial and the lateral talar neck lengths we also standardized. So this is the anterior most point of the lateral process of the talus. And if we draw a transverse line through this parallel to the talar body, we can then measure the length from this line to the medial and the lateral borders of the talus head, and this is how we can standardize the measurement of the talar neck lengths.
And the definition of the head is the junction of the articular surface with the
Yes,
normal bone.
the
Where
junction.
the articular surface finishes.
Yes, the junction of the articular surface with the normal bone, with the talar neck. So this is how we would typically measure it on an standardized axial CT plane. This is a line parallel to the talar body, passing through the lateral process of the talus. And if you draw perpendiculars from this line, it tells you the medial and the lateral talar neck lengths. So we also standardized the inclination angle. This is how we calculated the center of the talar head, the superior most point of the talar dome, and the posterior most point of the posterior process. And by joining these 2 points, we can get the inclination angle. So for the torsion angle, we took 2 points, medial and lateral, on the talar dome. This is one line which represents the talus body. The talus head, we chose 2 points proximally, took the center point, 2 points medially, distally, took the center point. This is the talus head axis, and the angle between the two tells you the torsion angle. So having standardized these planes and the measurements, we then took CT studies, and from these CT studies, we generated axial sections and other MPR sections, and also 3D models, and then compared these angles on the 3D model and the 2D model, so as to see if the 2D and the 3D measurements would agree. And we saw that they agreed to a large extent. As you can see here, the t-test showed that there was no significant difference between the volume rendered and the CT MPR based measurements. And we were also able to demonstrate that angular measurements agree within 10 degrees, linear measurements agree within 5 millimeters. So this is something which is clinically relevant.
Can we stop here for a minute?
Yes, sir.
Number one. So if you are doing these measurements for the inclination angle, does the presence or absence of a STIDAS process affect you? You could have an ostrigonal, or you could have a big STIDAS process. Do you think that will make a difference? And in your, how many cases did you see? How many did you encounter this little problem?
Yeah. So, sir, the question, so again, I'm repeating it for the online audience. What happens if there is a STIDAS process? Because the STIDAS is an elongation of the posterior process. So for this particular study, we excluded all the people who had congenital deformities. But this is something that orthopedic surgeons need to be aware of. And it can definitely, so if you have an anatomical abnormality, of course, it can create problems. And in that case, you just have to choose the best possible point. But this could be a potential source for error.
And how many cases did you evaluate for the CT?
Sir, for the feasibility, 15 cases, and for the reliability, 35 cases.
Okay. Thank you.
So for the reliability study, we chose 35 CT studies. We included 3 orthopedic surgeons as volunteers and had them do all these measurements on CT scan based images. We repeated these measurements 4 weeks apart. So we saw that the intra-observer reliability was good for all of the parameters except for the torsion angle. Similarly, the intra-observer reliability was also good except for the torsion angle. And then we also went ahead and described the minimum clinically important difference, MCID, for all of these values. So as you can see, for the torsion and the declination angle, it is nearly 8 degrees. So this was a limitation which we saw. Why did we encounter this problem? Well, because the talus is a small bone and small errors can be magnified into large inaccuracies. Also, the shape of the talus can be very variable. So when orthopedic surgeons choose landmarks, there can be differences. So 2 people may not choose the medial and the lateral landmarks the same. This is a sort of human variation that we saw. So how do we improve this? So one of the things that we thought of was to create a semi-automated tool. So we worked on this software called GeoGebra. So the landmarks here, as you can see, are being chosen by the orthopedic surgeon. So you define the talus head and the talus dome, and the software actually calculates the measurement on its own. So the variability in measuring the angles is taken care of. Of course, the best thing would be to have a completely automated, maybe an AI-based segmentation, which can identify the landmarks and also do the measurements. This is something for the future. And I don't know if my good friend Matthias Piefer is here, but he's already worked on automated segmentation of the ankle. Hopefully we can have it for the talus in future. So again, this is an automated measurement or semi-automated measurement of the inclination angle, where you just have to define the points. These are all described, and then the software does the measurements. So the same thing for the neck length and the torsion was also described. So having done this, we then looked at the normal values. So we took 200 CT studies and looked at all of these parameters. We saw that the inclination angle in the Indian population was a little less. The other angles were more or less same. And for the first time, we described what the medial neck length should be. Then the literature typically says that talus necks are in varus, but this French study was the first one to show the concept of a valgus neck. Well, we also saw that some of our necks were in valgus, and this is important for orthopedic surgeons to know when they are reducing talus neck fractures.
Could we stop here?
Yes, sir.
And maybe we can have the external examiners. Dr. Lalit Mani, can you hear me? Dr. Abhay, can you hear me?
Sir.
Can you hear me,
Yes.
Dr. Abhay and Dr. So we've had two objectives. And Siddhartha, would you enumerate the objectives again? If you have any questions or comments, we'll go on to that.
So the two objectives were to standardize the measurement techniques for talus neck geometry and to look at those normal values in the Indian population.
So we already have some values from the
literature. Some of them.
but not all of them.
Not all
because
of
some of them you made up on your own.
Yes.
Okay. Any questions from anybody in the audience? The examiners, please. Any comments or questions, sir?
So once you did the study, what were the basic inter and intra-observational errors when you did the rotational measurements? Because I believe those were the only things in which the independent observers were different in their measurements.
So, sir, the ICC for all of the measurements were good. For the torsion angle, it was pretty poor. It was almost 0.4. And this is one of the limitations, sir.
So yeah, I agree, because the whole point is that once you are measuring malunions, where your torsional deviations may be the most significant ones, and it is your torsional measurement which has the maximum amount of variability in your measurement, and sometimes one actually can get very error-prone measurements in your torsional measurements in talar malunions.
Yes, so we completely agree with that, which is why we also went ahead and did something on the 3D models. So we did a 3D overlap analysis so that this will be presented in the later part of the work. So that was an offshoot from the limitation of the study. So we tried to improve on those limitations, sir.
Yeah, one thing. Just on the same. The moment it becomes automated, it's a solution to take out this interreliability problems and all. Because then the system itself, it's AI based, when it starts realizing how the bone is. So which I think you are working on already. It's automated.
So yes, I agree with you, Sandeep. Automated measurements is definitely the way forward. They can remove all of these inaccuracies.
Okay.
So, sir, with your permission, can I move forwards?
So,
Yeah, please.
Siddhartha, one question from my side.
Yes, sir.
So, I would like to know why did you end up with this thesis at all? I agree that talus malunions are not addressed well in the literature, but it must have been some pushing clinical scenarios which brought you to this thesis. And also, when we manage these fractures, whether it is preoperative or intraoperative, it's more X-ray based. However, most of your measurements till now you have discussed are CT based. And finally, the planes, when you were deciding the planes, there was human intervention there. So if there can be a variability even in deciding the planes, especially when there is a malunion. So can you address these 3 points, please?
Yes, sir. Thank you, sir. So the first question, why we chose this topic, because we are principally a foot and ankle team. And I agree, we may be seeing more cases than the average orthopedic surgeons, but we are seeing these cases very frequently, sir. And we realize that they are probably not being operated. Also, we saw that malunions are a bigger problem in terms of functional deficit than avascular necrosis. And talus is possibly the only bone in the body which has no angular measurements. So if you wanted to quantify the reduction anywhere from a clavicle down to the ankle, you have some angular parameters. But the talus, unfortunately, is the only orphan bone which has no such parameters. And I do agree that these measurements are on CT scans. X-rays, getting a good projection of the talus, well, on the lateral view is easy. Others is not so easy. But orthopedic surgeons are getting post-operative CTs these days. So it is possible to look at these measurements post-operatively. And if there is a big problem, there is always a scope to go back and to make it better. About the automation thing, sir, yes, I do agree. When we started this work in 2019, AI was still creeping its way into orthopedics, but this is something we do plan to address in the future, having fully automated measurements which reduce the human element at all, so that there is no component of a human error, sir.
So another
even
question which sorry.
Finally, the selection of the planes which we have done, again, that should also have some validation studies on the accuracy of selection of the planes itself.
Right, sir. This is also something that we are aiming to do, sir.
Good.
So another thought that pops up into the mind, especially when you're measuring talus malunions, and especially when you say that the valgus in the talus is also a very real entity. How does one quantify as to whether the valgus is part of the malunion or it is actually a pre-existing thing, unless you've done the similar measurements on the contralateral side, which is non-injured? So all with respect valgus, would you go back and study the contralateral talar measurements and then actually quantify as to how you are on the injured side?
Yes, sir, absolutely. So fortunately, most of these cases are unilateral. We have not seen bilateral malunion, so we should always look at the opposite side.
The question was
Sir.
that if you suspect that a malunion is unusual, would you do a contra? That is exactly what you are doing.
Yes.
That's
So
the next objective.
we are routinely segmenting both of the tali, sir. So in all of our malunion cases, we look at the measurements on the normal side and the abnormal side, and we only call it a valgus if we can see, some sort of a similar thing on the other side, sir. So the normal side, so in the malunions that we called valgus, the normal side was in varus, sir.
Would you have any idea in the sense that are the varus malunions more painful or is the valgus malunion more painful, which would also give an idea about the deforming force on the ankle and the talus at the time of the injury. So basically, which type of an injury and which type of a deformation is more damaging to the big talar architecture?
So, sir, from a statistical viewpoint,
would you have an idea?
Yes, sir.
So would you have you been able to quantify whether your varus malunions were more clinically symptomatic or your valgus malunions were more clinically symptomatic?
Yes, sir. So, sir, from a statistical viewpoint, because we had only 10 cases, so we did not find any significant p values. But from a clinical viewpoint, we can say that the valgus ones were actually the ones that had a valgus of the neck with a dislocated subtalar joint. So the overall foot deformity was still varus. And in these cases, the subtalar dislocation with the talus neck fracture had not been addressed principally. So these patients were limping, they were more painful, they had a more severe hindfoot varus. And when we went in to correct them surgically, it was more problematic for us.
May I make a comment here, Dr. Abhay? The issue over here is that when we are looking at the radiological parameters, we are tending to neglect the other associated things like the subtalar joint, the talonavicular joint, or any residual problems in the ankle. So when we finish the next three objectives, you will find out how this has been quantified by mirror imaging with the opposite foot. So we will know more of that. And this is exactly what was one of the aims of this thesis, was to try and see that after quantify, will we be able to do a clinical correlation? Now, outside his thesis, we've got about almost 50-60 malunions of the talus in the last 5 years. But for his thesis, we've only been able to use 10 cases.
Sir, should I move on?
Yeah, please do.
Thank you, sir. So the third objective was to look at people who were operated for a talus neck fracture, define their talus neck reduction, and look how this affected their functional outcomes and foot biomechanics. So we hypothesized that even after a well fixed or a good looking fracture reduction, there would be some changes in anatomy which would translate into pedobarographic alterations. So because of COVID, we did have some problems recruiting the patients. We had 20 patients in which we did X-rays and CTs. We looked at functional outcomes, and we also did dynamic pedobarography. So these are the baseline characteristics. It was a young population with predominance of males. All of these underwent operative fixation with a mean follow-up of approximately 13 months. Now I'm just showing the significant results here. Although we looked at a whole gamut of parameters, we saw that the forefoot pressures were actually decreased on the side of the talus neck fracture. The swing phase was increased, and the single limb support, which is the center of pressure measurement, which tells you how much time the patient is spending on that foot, had also decreased. So the inference from this, I would say it is an underpowered study because we only had 20 cases, but we did show that there was a change in the foot biomechanics happening, and the patients did have maybe a slightly antalgic gait or something, but there was something definitely going on here. We do plan to increase the sample size and look at this in more detail as we have more and more operative fractured neck talus cases. So the next objective was to look at people who had a gross talus malunion. In the previous objective, we only included people who were fixed, but the foot shape looked okay and the X-rays grossly looked okay. For this objective, we chose people with a gross talus neck malunion and what was its effect on foot anatomy. Alongside, I will also be telling you the effect on foot biomechanics and functional outcomes. So this was a case control study where we chose the side with the talus malunion as cases and the opposite side as controls. So we enrolled these cases, did X-rays and CT scans, and then looked at the functional outcomes and foot pressures. For the X-rays, we looked at the Meary's angle in the AP and the lateral radiographs. We looked at the hind foot movement arm, and then we did all of those parameters on CTs, which I've already shown you. So this is how the Meary's angles were measured. This is the standard description of a hind foot movement arm. The angles measurements are the ones that I have previously described. And then we also, standardized and defined the pathoanatomy in 3 dimensions. So we took CT studies, segmented the talus out of it, defined a standard coordinate system, which is based on a published publication in the literature, and then used GeoGebra to perform semi-automated measurements, which I have shown before. So the segmentation was done on Mimics, which was made available to us through a partner in the Punjab Engineering College. So this is a pretty standard way to segment the talus. We use the CT bone algorithm to segment it out like that. We generated a 3D model. For standardizing the talus neck planes, we selected this publication by Nozaki et al. So these are all the landmarks which have been described by Nozaki. And then once you have these landmarks, you can go ahead and define the standard axial, sagittal, and the coronal planes. Then we also did a 3D overlap analysis, and a big shout out thank you to my friend Matthias Piefer, who has done this amazing work in ankle, where he is doing the biomechanics as well as 3D model overlaps. So we imported the 3D models into 3matic, we mirrored them, did a registration, and did a fine tuning manually, which I will now show you. So here you can see that the talus models of the normal and the abnormal side have been imported into the 3matic software. So we are using the normal talus 3D model as a template, and we create a mirror image of the abnormal side. So after you've created a mirror image, we do something known as an endpoints registration. So on the 2 models, you are going to define 3 or 4 standard anatomical points. So you're going to tell the software, this is the medial neck, the lateral neck, and then the software will align those two bones on the basis of the points that you have described. So this is the first step in doing an overlap analysis. The first point, this is the second point, and the third point, which is the lateral process. It doesn't have to be super accurate because this is really the first step, but this is the talus mirroring first step. The next step is to do a global registration. So now you're telling the software to match all the points of the Malunion 3D model on the normal 3D model. And the software will try to do a best possible job as much as it can. And this is pretty accurate. So after you have done this, we do a little bit of a manual fine tuning. So we know that in a talus neck malunion, the talus body is more or less okay. All of the deformity is at the front. So we try to align the talus bodies of the two sides, the normal and the abnormal, to match each other. So after you've done rigorously all of these three steps, you have your overlapped models ready for analysis, which I will show you shortly. So we had a total of 14 patients come in, out of which 4 were excluded because of the talus was deformed. And we finally included 10 people. We classified them as per the Hamilton's WIP classification. These are the details. And interestingly, we noted that the torsion angle was significantly decreased in the side with malunion. And this measurement was a semi-automated measurement, so we have more confidence in this than the manual measurements. We also saw that the declination angle was nearly approaching statistical significance. So when we did a subgroup analysis of the people with a varus and a valgus neck, we saw that people who have normally a varus neck also had a significantly higher declination angle on the malunion side. So we correlated this thing with the foot anatomy, and we saw that a declination angle change also changes the hindfoot moment arm. The torsion angle changes the foot AP and the lateral Meares angle, and a decrease in the talus neck length alters the foot shape in all 3 planes, as you can see here. So this is what our overlapped models look like. The white model is the normal talus, the red is the malunited talus. In the axial plane, we saw a whole spectrum of deformities, ranging from a mild varus on the left side to a moderate varus, and then a severe degree of varus, as the model on the right side shows. This is the non-overlapped model, and even in the non-overlapped model, you can see that there is a lot of difference. So this is the point of the valgus malunion. So we had 2 cases where the talus neck was actually going into valgus. Both of these cases had a dislocated subtalar joint, which is why the foot looked clinically in varus, but the talus neck was in valgus. So this is what it looks like. In the coronal plane, we consistently noted that the rotation or the torsion was decreased. This was the case in all of our cases. For the sagittal plane, we noted that the talus neck was commonly dorsiflexed. This is what a dorsiflexion malunion would look like. But in 6 cases, it was also plantarflexed. So which means that it can go in any of these directions. So then to really quantify what the deformity is, we also did something known as distance mapping. So to just sort of show the audience what a distance map is, this is a talus model. And then we have created a mirror image of that talus model. And we have overlapped the 2. And a distance map will show you the difference between 2 points on those 3D models. Now in this particular image, everything is red, which means that there is no difference. But when we looked at our mirrored images, you will appreciate that the reds indicate up to a 5 millimeter difference or even more. So the distance mapping actually confirmed the presence of all of these deformities which we are talking about. So the inferences from this study was that not all malunions are in varus. Sometimes you can have different sorts of deformities in the axial as well as the sagittal plane. But the consistent deformity in the coronal plane was a decreased torsion, which really nobody has talked about so far. And a decrease in the medial neck length, not only does it cause varus, but it also leads to cavus and a change in the hindfoot alignment. A decrease in the torsion angle contributes to adduction and also leads to a cavus deformity. So sir, should I pause here?
We can ask if there are any questions.
Sir, if there are any questions.
Or you want to go on?
to understand what you're saying, that in case you have a flexion malunion of the neck of the talus, the patient clinically will present with a cavus foot. And if you had an exaggerated varus torsional malunion, the patient would have a significant hind leg and a hind foot deformation. And if you had a valgus malunion, probably these are the patients who would tend to go towards a skew foot. Is that right?
Yes, sir. So if they had a valgus foot with an intact subtalar joint, but both of these patients in our had a medial subtalar dislocation. So the subtalar joint was dislocated. So the overall anatomy was also, the foot shape was in varus for both of those cases.
As a forerunner, it would be a very nice thing to actually go ahead and do an MRI documentation of joints show more arthritic changes or cartilage changes as a comparison of all these three groups. Probably that would be a very good correlation clinically. An easier thing to do for the normal orthopedic surgeon rather who does not have access to such complicated CT understanding of talar deformation and deformities.
Yes, yes. Dr. Dhillon wants to say something.
I have a comment on this. I think these are very good points which Dr. Abhay is making. The issue over here is it also depends upon when we identify the talus malunion. Many times we identify the talus malunion within a few days of the surgery. Before any arthritic changes have come in, maybe there's a subluxated subtalar joint and a torsion, etc. That is the time when you can sort of just take out everything and perhaps correct it. And if we can get this model at that time, it is best. However, many of them come to you 3 months, 6 months, 12 months, 2 years down the line. I have operated on some of these cases who come to me 3 years down the line. So all this then becomes very, very different, because here the joints are not salvageable. We are trying to make some kind of a model which will tell you maybe immediate post-operatively that this is a talus which is not accurately reduced. Do something for this now, otherwise later on there will be a clinical problem. But that we are just early days. So this is just a planning kind of a preliminary work which we are trying to do. And I do agree, when we get them later on, there are other things which come into play.
So I have just one more question, Dr. Siddhartha, that did you observe which one of these three malunions were more associated with clinical subluxation at the subtalar joint?
So, sir, within the small numbers possible, we did not get any statistical significance. But as our numbers continue to grow, this is one question that we hope to be able to answer.
My personal experience
is
that if there is a significant dorsiflexion, subtalar joint is invariably unreduced.
Yes. Dr. Dhillon says if the dorsiflexion malunion is the one with the highest degree of subtalar dislocation.
Yeah, because these are patients who would actually also have a flattening of the transverse arch and then splaying of the foot and more painful.
Yes.
Yeah.
Yes.
Okay.
One more thing, I think this is the first time that the valgus and plantar flexion deformities have been revealed.
Yes.
What we always thought was it was always varus and dorsiflexion. But I think you have been able to define the other variants.
Yes.
But the foot is always in cavovarus.
So in all of our 10 cases, the foot was, the shape of the foot was cavovarus, but the talus was, sometimes in valgus, sometimes in varus.
I have to admit, I have been working on talus for 30 years. I never thought there would be a plantar flexion deformity.
Right.
And because foot is in cavovarus, we end up thinking that they are actually varus and dorsiflexion, but still they had...
Yes, this becomes so much important when you're thinking of whether to put in a graft to distract the medial talus. Because then the varus is coming from the subtalar joint and you need to address that varus. You don't really need to lengthen the talus neck even more.
You have to do it the other way.
Yes, so you may, so we actually never shortened the neck in a valgus malunion. We only had 2 cases, but those are the cases where you don't need a medial interposition graft. So within the small numbers, it is, maybe we cannot state with a statistical significance, but yes, clinically we did observe this.
Right.
So the next objective was to look at the foot biomechanics through means of a dynamic pedobarography.
Siddhartha,
Sir.
can I just ask you 2 questions?
Yes, sir.
One is that I suppose you mentioned that you took control as a normal side or the normal subject?
The normal side, sir.
Normal side. Because in pedobarography there might be false values on the normal side because the gate cycle is getting affected by the malunion. As you said, the stance phase is elongated on the normal side. Is that right?
It is absolutely right, sir. And this is a big limitation of pedobarography, also of gait analysis, because a person who has had a fracture on one side would perhaps never have a normal gait or a normal side. But this is the best sort of control that we could have. So, because everything else is matched to the patient's physiology and anatomy, but in a true sense, in the strictest sense of the word, it is never a normal gait. That is a limitation, sir.
And quantification of your malunion by the overlap technique, where you were looking at the distance mapping, could you come out with the quantification of the length, torsion, and varus valgus by the overlap technique, or you just looked into the angles?
So, sir, we can actually calculate on each point of the talus the difference from the normal side. I have just not shown it here, but it is a ton of data that is generated. We can actually compare each point to each point on the normal side and tell what is the difference. We can also do something. So, I have actually also created a statistical shape model, so which we will show later, but it also tells you sort of the average sort of difference when we have this.
Okay, go ahead.
Thank you, sir. So moving on to the next objective, the pedobarography. So we hypothesized that there would be a significant change in the gait and plantar pressures, and this would be correlated with the change in the anatomy. So these are the standard parameters that you would get out of a gait analysis. So you have some of the gait analysis parameters. Now this is not really a formal marker based gait analysis, but it does give you some basic parameters. And then importantly, it tells you the distribution of pressures in different zones. So the results from this gait analysis, we showed that the step length on the Malunion side was increased, the single limb support side was decreased, and the step time was increased, indicating thereby that people were spending less time in the stance phase on the side with malunion. Now the center of pressure analysis tells you the progression of pressure, and in a normal foot, it goes from posterior to the anterior side, and then you have this line which you see here, which is known as the center of pressure line. And we saw that the single limb support line was significantly short in the malunion cases, which means that the stance phase was significantly affected. So here you can see on the normal side, this is the normal COP line progressing from posterior to anterior, but on the malunion side, this was significantly shortened. So then we moved on to look at the zone-wise pressure analysis, and we saw that the midfoot pressures were significantly increased, the midfoot forces were significantly increased, and correspondingly the forefoot and the hindfoot forces were decreased. So this is a dynamic footprint. On the normal side, you see a normal pressure concentration in the forefoot and the hindfoot, but on the malunion side, you can see a clear high pressure area extending from the midfoot to the forefoot. Correspondingly, the normal pressure area in the forefoot is absent. So this was a consistent finding in all of our cases. When we correlated this with the foot geometry, we saw that the inclination angle had a significant correlation with the forefoot and hindfoot forces, and the torsion angle significantly changed the midfoot forces. So the inference from this study is that talus malunions result in significant gait abnormalities. They result in an increase in the midfoot forces with a decrease in the hindfoot forces. The dorsiflexion malunion decreases the forces in the forefoot and midfoot, and a change in the torsion angle increases the midfoot pressures. So why does this happen? So this is a model showing you a normal alignment. When you have a dorsiflexion malunion, the first ray goes up. And now to have a plantar flex, to have a plantigrade foot, the first toe, the first ray, the metatarsal has to drop down. This is the beginning of a cavovarus deformity. Also, when you have a talus neck malunion with a decrease in the torsion, as you can see here. So this is a model where we are trying to show what happens when you have an external rotation. So in this case, the first ray goes up. And the only way that the foot can now touch the ground is for the first ray to plantar flex. When that happens, similar to a cavo-varus deformity, the hind foot also follows into varus and you have a cavo-varus deformity. So after doing this, we looked at the functional outcomes. For this, we chose some standard scores. We took the MOX FQ, the EQ5D score, VAS score. We looked at the range of motions. The MOX FQ score is described in Hindi, in English, but we actually did a formal transliteration with the Oxford University into the Hindi. This is the Hindi version of the MOX FQ score. For the EQ5D, the Hindi version was already available. These are the results, and I will show you how they correlated. On the Malunion side, we saw that the inversion eversion was significantly affected. No surprises there. But interestingly, we saw that an increase in the midfoot pressure led to a bad or increase in the VAS score. The midfoot forces and the midfoot pressures which were increased translated into bad EQ5D walking and usual activities. And an increased midfoot pressure also worsened the MOX FQ scores. So we were able to show the relationship of the anatomy with the worsening foot biomechanics and the worsening foot biomechanics with the worsening functional outcomes here. So these are the inferences which I have already mentioned. So sir, would we want to stop here? Or should I go on?
This is the last objective.
This is the last
Then
objective.
we can have a discussion after that.
Yeah, please go ahead.
Okay. So the final objective was to develop 3D printed models, and it makes me a little nervous to be in the presence of Professor Lalit Mani, who is a stalwart on 3D printing. But in 2019, when we started this, sir.
Don't be nervous, I'll be supportive.
Thank you, sir. So when we started, we just wanted to get a feel of 3D printing, introduce this as a service in our department. So this is a very, very basic desktop 3D printer, which I procured and learned how to 3D print. This is a 3D printed Talus being printed in progress. Doesn't look very fancy, but it is what it is. So we did create some prototypes, looked at it. I don't really have p-values to show you what it is. But then I was fortunate enough to train at Fairhill at Mass General Hospital. And there with the help of Matthias and Bedri, and of course with Sohail, we were able to design some patient-specific jigs. So this is one of the jigs, the designs of the jig for a talus neck osteotomy, which we do plan to use for a corrective talar neck osteotomy. This is what the printed 3D jig looks like. It has slots for pins in the talus to be able to fix it. And then it allows a 5 mm osteotome to pass, and you can actually guide the correction. So the inference is that, of course, 3D models can help us in understanding the pathoanatomy. We can use it to teach residents. And now we are starting to look at patient-specific jigs to improve the accuracy of our corrections. So the summary of this thesis is that we standardize the measurement techniques for talus neck geometry on CT scans as well as on 3D models. We described the normal values of the talus neck in our population. We were able to show that malunion has a significant change in foot anatomy, which leads to a change in biomechanics, which in turn leads to bad functional outcomes. And we were able to come up with some 3D printing and 3D modeling techniques, which may not be the last answer, but it may be a good armamentarium in the pocket of an orthopedic surgeon when you are evaluating these difficult decisions. So in other words, I've already shown you, we did a cross-cultural adaptation of the MOX FQ score. We will come out with that publication soon. We, from the subset of the data that we had, we published, we are planning to publish a study on open talus neck fractures. We've already published extruded talus study. Again, this comes from our foot and ankle databases. 2 of our publications are almost accepted, they are there. And then finally, I was able to, with the help of, again, my good friend Matthias and Bedri, we were able to create the statistical shape model, which shows you what an average talus neck malunion should look like in 3 dimensions. So it has components of varus, decreased torsion, and dorsiflexion, which are the common, because the statistical model will tell you the common things here. So we did have a few presentations. We were fortunate enough to get a research grant, a few medals, and notably Dr. Sandeep presented a part of this work and got the AO Research Olympiad. It was a very proud moment for us. We have a few publications. There are more. in progress. And at the end of it all, I humbly stand before you, thanking everyone who has helped me in this journey. Thank you, all of my guides, my mentors, especially our patients who have an extreme degree of trust in us, my DC members, co-guides, all of my research fellows, our staff. Thank you, all of my friends at Ferrell, Sohail, Bedri, Matias, all of the team there. Ata, I know you are here. And somebody's name I have just missed. Please, apologies from my end. Thank you. And now we are open for questions.
As part of the Viva, with any questions from the external examiners and any queries from the audience over here? Yeah, we have a question from Atia. Can you just, he's raised his hand.
Ata, I think he was just, it was just a clapping, or do you actually want to?
Yeah, I was clapping actually.
Okay, thank you, man. Thank you.
So, Siddhartha, about the pedobarography, how significant or accurate do you think this investigation is? Why I'm asking this is, maybe if a patient comes in a follow-up at 6 months or 2 years, and you do a pedobarography, can it be a useful tool in guiding you on, that there is a malunion even before getting a CT or those complicated angles to be measured?
Yes, sir, absolutely. So the machine that we have is a dynamic pedobarography. So what we have the patient, it is covered on a mat, so the patient doesn't know where the platform starts and stops. So they are just trying to walk naturally. And we make them walk a minimum of 3 times. And whatever we are taking is the average of all of those values. So it tells you very quickly changes in the gait. To do a formal gait analysis takes about half an hour. The patient has to strip. But this thing is giving you a very good gait analysis in a very brief way. It is telling you the high pressure zones. So even if you want to manage this patient non-operatively, you could possibly prescribe insoles. And of course, it also helps you to understand where the high pressures are and plan your correction that way.
Similar to like you do in Charcot's?
Similar to Charcot's and other foot deformities, sir.
Good.
Thank you.
Dr. Abhay, you have a question?
My only submission is that gross malunions. The subtle malunions would also create differences into the clinical outcome of any patient with talar injury, with not a very perfect restoration of what was normal or what was similar to the contralateral side. So how does one actually suspect a malunion when you're actually, our basic assessment is mainly radiography? And unless, the general public is well trained into CT assessment of these complicated angles. So that's one. The other thing is that as a clinical usage standpoint and the applicability of such good research into normal practice, I think what you could also suggest and come out with is what kind of changes are routinely observed in the gait patterns observed or the force plate analysis, or on the MRI patterns if these patients come to certain clinicians at, let's say, 6 weeks at follow-up or 2 months at follow-up. And that probably would be a more understandable guide as to how and where to direct treatments.
Thank you, sir. So we are already in the process of, we have the gait machine. We are already compiling the database of pedobarography. And with the help of AI, we may be actually able to sort of group them into certain patterns, because it is very difficult to have, just a simple anatomy and say that this is normal, but this is abnormal. But AI actually helps you to define certain clusters. And, with those things, we may be able to. Regarding the clinical applicability, we have already started getting MRIs for this. We have started those things as well. But I agree with all of those points. These are great suggestions.
I have a comment. May I make a comment, guys? As one of the issues why we brought it up was as your Farrell colleagues are talking about ankle. One of the commonest issues which people never understood for many years was the malreduction of the syndesmosis. Every orthopedic surgeon will do an ankle fracture and put a screw in the syndesmosis. And for many years, the only discussion was where to put the screw, not how to put the screw and how to reduce the syndesmosis. It was only when people routinely started using CTs in painful ankles, they found that there was a 40% malreduction rate in syndesmotic fixation, 40. And this was Gardner's study in 2004 or 2005. Now in centers like us, we either use intraoperative CT, postoperative CT, or intraoperative accurate reduction by open means from the front. So this is a corollary from that. This is much more complex than a syndesmosis. But now almost everybody in this orthopedic fraternity understands that there is a possibility of syndesmotic malunion. The aim of this study is to tell people. I mean, we were teaching when I've got two subtle malunions of sons of my friends. Siddhartha follows up one of them, who's got a mild varus malunion. But he's working as a pilot and his foot has adapted because his subtalar joint and ankle joint and talonavical joint were mobile. We are looking at the gross ones and we are trying to put the concept out there that this thing exists. And if we pick it up early, we got our study on Talus malunion, which is published in Injury or accepted in Injury, is working on this. If you pick it up early, you probably need to do something early. Yes.
Yeah. So one more thing, as Sir rightly pointed out, the clinical utility. I think, as Sir also put it up, there are subtle malunions and gross malunions. So I think the patient will come to us when they have a gross malunion or some problematic. So we don't know because those subtle malunions may not end up coming to us. But the biggest clinical applicability, especially because I've been with you, I've seen you working, is it has given us a better understanding of how to go and correct them. I think that has been a bigger learning. Like the torsion thing was never discussed. We never knew that. So, and you have the last two cases, I think you corrected by correcting the torsion. So these are new things which is actually adding to the clinical utility as a surgeon's perspective. We better understand the deformities, and those deformities are case specific. And because of your overlap technique, it was revealed to us. And now we can just do it the opposite way.
Okay. Anybody else? Any comments? Final comments from the external examiners and then your judgment call.
So Siddhartha, I think it's an excellent initiative on, making people aware about this problem, and also secondly, quantifying it and what it is, and thirdly, on also creating a 3D model on which you can plan up your corrective procedures to address this. I think maybe if we can continue these studies with a larger sample size and at different centers, then it really makes it a measurement for Indian population, because despite people coming to you from different regions, it would still not be covering the whole Indian population as a matter of fact. And if we can sort of do it in maybe few centers, just measurements of the angles, that itself will strengthen our understanding on the parameters for Indian populations. So
Yes.
overall, I would like to congratulate you on this excellent work, and being a fan and an enthusiast of 3D printing, I'm happy that you have incorporated it in improving outcome for foot and ankle problems. Thank you.
Thank you, sir.
Dr. Abhay, your comments, sir?
Yeah, so one very fascinating thing which comes to mind is that if you can follow up some of these patients which you have already, even if you've not considered them amongst the 10 patients, it would be really nice to see over a period of, let's say, 1 year, as to which are the malunions which have actually remodeled into more physiologic function and in terms of more physiologic CT base. So, if you can actually say that this amount of malunion is the one which needs a correction and will not correct over 1 year, and this is what will be fine because of inherent mobility of the ankle and the subtalar complex. And that actually would be a very significant and a practical guide based on the excellent study that you've done.
Thank you, sir.
Because
I think, yeah, sir. I'll make a comment for the last one. Over the years, I think I fixed my first Talus in 1991. And over the time, I've learned that the ones which I thought were very beautifully fixed. The first one, we always used to put 2 screws from the medial side. And many of them, I have follow-ups of almost 18-20 years. Some of them who had a subtle malunion have a little pain. They have a little pain for longer periods of time. But if their subtalar and talonavicular joints are mobile, they adapt. And if they are younger age group, the older age group, they usually really don't adapt. The gross malunions, we really don't want to wait. We want to do something to prevent the permanent deterioration of the whole foot's biomechanics. Anyway, that is my experience. Siddharth's been working on it. They will work on it much longer than I, after I retire or after I die, they'll still go on working on it. And I'm very glad to say that I'm proud of the foot and ankle team which we've developed in PGI. They've done a very good job. There are 3 of them, 4 of them. Now everybody wants to leave everything else and do foot and ankle surgery. Thank you, sir. Dr. Mani and Dr. Ellens, would you give a thumbs up or a thumbs down?
Oh, thumbs up any day. Beautiful work.
Okay, so so we would consider this thesis passed. We would get your official report by email, sign it and send it to me. But otherwise, we would consider this passed. Why I'm asking is the audience is desperately waiting for a party.
So are we. So are we.
Okay, sir. Thank you so much for joining us. And with this, I'd like to end formally the thesis defense. Sorry for taking up so much of your time. Thank you so much.
Thank you.
Thank you, sir.